Hello, this is Johanna Mast, and this is my presentation on HIV/AIDS in South Africa. As you can see, HIV/AIDS is affecting South Africa disproportionately to the rest of Africa and is one of the premier spots globally for the spread of HIV/AIDS as far as percentage of the population. So, huge issue. First, I looked at Lemarquis, or Lamarcus, from the Medical Anthropology Quarterly, and he did an anthropological study involved with people living with AIDS, where he went to two towns in South Africa, and he lived with those people for a certain amount of time to gain understanding about how their lived experience and their mundane life built their identities and their self-determination as people living with AIDS. He also begins this review with the introduction of certain anthropological terms, the most important of which, for my purposes, is biological citizenship. This idea that citizenship can be partly dependent on biological factors rather than legal or social. That you having biologically a certain disease or you having biologically, let's say, the ability to bear a child or whatever, that this will affect your citizenship and your relationship to the state and your social relationship. And he does several case studies of various specific people and how their everyday lives are affected by having HIV in South Africa. Then we go to McNeil from the New York Times, and this is just an overview of three organizations involved with PEPFAR. These are non-governmental organizations, and PEPFAR is funded by the US government. I believe not anymore, but as of 2014, it was. He begins each section by introducing different medical professionals, giving their interviews and their perspectives on various issues related to HIV/AIDS in South Africa. So for care of people involved in sex work, especially government funding and how that affects medical innovation, and focusing on barriers to care created through government and the importance of access to information from doctor to patient. Then we have the importance of structural violence. So this is a form of invisible violence that is built upon inequities in economic, social, and other structures. You think apartheid in South Africa, this is a long-standing legal system of discrimination. And even though it does not exist anymore, because the society is built around apartheid, it replicates that inequality and that violence through its medical structures. So this is barriers to care through physicality of having care centers only located in rich or whiter areas, barriers to transportation, and then other barriers of people having poor health due to poor nutrition or poor access to water or sanitation. And this really affects medical access. And access to care with HIV/AIDS, because HIV/AIDS primarily affects Black South Africans as opposed to white South Africans. The benefits of community. So community is really important to helping break down those inequities. It allows access to knowledge within communities between people who have unequal access to medical care. Someone who is able to get sex education, sharing that knowledge to someone else they know who may not be able to access that education directly. And social support as a key factor of health that when doctors go into the communities that they are trying to help and they involve themselves in these places, that providing that social support as well as medical support allows people to have a more consistent access to healthcare and allows people to feel more confident in against the stigma of having HIV/AIDS. Then there is this concept of biopower, which is super important, which is self-regulation. See the panopticon, self-regulation due to the structure of society and the structure of power in society, to say, I must keep up with a certain level of health. And that is my responsibility as a member of society. And this is super important with HIV/AIDS because it is a sexually transmitted disease. And there's oftentimes this misconception or this perception that people who get HIV/AIDS through intravenous drug use or through sex work, that they are simply, quote unquote, not taking care of themselves, and that it is the responsibility of the patient to prevent themselves from getting AIDS in the first place. And that if they haven't done that, they have failed somehow morally. And this can really prevent people from coming forward with an HIV/AIDS diagnosis in order to seek medical care, which is important because doctors don't have to disclose whether or not they have HIV/AIDS. And most of the time in South Africa, they do not. It is, which of course replicates this inequality between white or wealthier doctors and South African AIDS patients. So being able to break down that stigma through community and listen to the narratives of patients is something that's really important. And we also have the medical gaze. So this is a process of constructing illness where doctors take the symptoms of a patient and they create the narrative of illness. And going back with biopower, oftentimes this narrative surrounds this idea that you have failed to get proper treatment or you have failed to do this or that in order to keep yourself healthy. This relies on appeals to medical authority, to medical professionalism, and we even see this in the New York article where they're appealing to the medical professionals to tell us what it's like to treat people with HIV/AIDS, when really it's equally, if not way more important, to focus on what are these people living with HIV/AIDS saying about their experience. And the medical gaze helps to segregate these areas of knowledge where social connection and medical connection are disparate. And it also influences, again, medical reporting and communications. If someone, if we're getting a larger overview of public health and public health relations in South Africa, from people working with the government or people working with PEPFAR, and these people are not involved in the community, and they really don't care about listening to the perspectives of people with HIV/AIDS, then we get an inaccurate picture of the daily life and the daily struggles of people in this area. It also has to do with there are some support groups that and care groups that people are not allowed to access if they're not taking certain medical drugs. So again, going back to biopower, there's this idea of exclusivity of how do we make sure that medical care is equalized and we reach people and they are able to share their own narratives.